Alrighty, so let's get going. For the first case, which is a warm-up case, who wants the warm-up case? Elmo, do you want to start with that one?
Okay.
Okay, case one. It's always hard when someone says it's a warm-up case, right?
Yeah.
You'd much rather someone saying this is really hard, there's no chance of you getting it.
Exactly.
This is a really easy one.
Contrast MRI of the brain demonstrates a large extraaxial lesion centered within the left middle cranial fossa and involving the anterior cranial fossa. The lesion on T1 is hypo-intense and it is hyper-intense on T2. And it follows CSF.
And hypo to what?
To the grey matter or to the brain.
Right. So whenever you use relative terms like hypo or hyper, you have to make sure that it is clear what you're comparing it to.
Yep.
So if you're saying in a liver, or in, say there's a lesion in the middle of the white matter and you say a hyper intense lesion, then it's clear that you're comparing it to white matter. So it's okay. Mm-hmm. But if it's not clear what you're comparing it to, then hyper and hypo are relative terms. So you have to say compared to what.
Yep.
In this case, saying that it's a lesion that has signal intensity similar to CSF on both T1 and T2
yep.
is even better because when you're saying hypo, if someone's not seeing what you're seeing, then hypo just means less than, but it doesn't narrow it down more than saying it's less than this particular value. Whereas yep. saying what it's like, which is the same on CT, is more precise. So, yep, okay.
So on FLAIR, it completely suppresses.
Completely?
Yes. Actually.
What about posteriorly?
Yeah, there's a small ovoid area posteriorly that doesn't suppress.
Yep.
But this doesn't correspond to when. There's a small area on T2, there is a small region of ISO intensity relative to grey matter within this area of non-FLAIR suppression. On DWI and ADC, there's no abnormal diffusion restriction throughout the lesion. It exerts mass effect on the underlying brain with midline shift and effacement of the lateral ventricles, but there's no hydrocephalus and there's no other extraaxial lesion.
What does effacement mean?
Well, it distorts the contour of the lateral ventricle and compresses it and almost brings the two surfaces together.
Because effacement does not mean distorted, does it?
No.
It means obliterated. So if you say that a ventricle is effaced or a sulcus is effaced, it means it's gone.
Okay.
And here the ventricle's still there. It's narrowed. You can say partially effaced if you want.
Partial effacement.
Which is kind of like saying partial obliteration or somewhat pregnant, I suppose. Yep, okay.
And also, it's hard to completely assess the bones, but the overlying calvarium does appear thinned and the lesion has some scalloped margins.
Coronal T2 probably shows that the best, huh?
Yeah, I was looking on the axial, but yeah, it's better on the coronal. Yep. So in summary, the findings are in keeping with a large arachnoid cyst.
So how do you account for that non-FLAIR suppression posteriorly?
I'm not sure if it could be artifactual.
What do you mean by artifact?
I don't know if you can get sort of because of pulsations, if that can occur.
Absolutely. So any flow in CSF will... So put it this way. Just like flow on T2 will cause signal loss, in those same areas, you won't be able to attenuate the signal completely on flare. So the residual T2 signal, it's sort of the bit that's missing from T2 due to signal loss is what will remain on flare as failure of suppression. So this is just pulsation artifact. Yeah. And the thing that distinguishes it from an epidural, from an epidermoid cyst, for example, is it's really smooth. You know, we saw an epidermoid last time, right? And it has that coarse, dirty, ugly-looking flare, lack of suppression. Whereas this is a really smooth, fluffy area that looks kind of like when you see slow motion of ink in water. You know, that sort of slowly flowing diffusion pattern. That's what you'll see. And just notice that on flare, on every routine scan, and this person doesn't have it, but many, you'll have a similar area of failure of flow suppression in the frontal horn due to a jet of CSF through the foramina of Monro.
Yep.
Someone had a question about whether it's one foramen of Monro that drains both ventricles or whether there are two foramen of Monro. I haven't looked into it, but I've always thought there were two, since that goes to two ventricles. But apparently there's strong and robust disagreement among anatomists as to whether there's one or two. Anyone read that there's only one foramen of Monro?
I'd always thought there were two as well. Foramina of Monro was, but that's without having read anything necessarily. It's just kind of what I assumed.
Yeah, goes into two different places, right? So, yeah. Good. So that is an arachnoid cyst. They can be remarkably large, and scalloping of the overlying bone is a pretty typical feature. What would the differential be for this lesion? There isn't one, really. But when you first glance at it, what other entities might you consider?
An epidermoid cyst?
Yep. So epidermoid is largely a differential on CT or on circa 1991 MRI scanners. On modern scanners, really, the signal, even on flare and T2 and T1, is sufficiently different that for a sizable lesion, you're really never in doubt. Yep, but that's good. Yep. What else?
Well, encephalomalacia, like just based on the signal characteristics.
Yep, so cystic encephalomalacia, and along that line, if it's communicating with the ventricles or subarachnoid space, we would call it starts with P.
Porencephalic cyst?
Yeah, porencephalic cyst. And so what's the key finding there?
It should be lined by white matter.
Yeah, by gliotic usually, unless it's happened before the third trimester of pregnancy, usually by gliotic white matter. Whereas here you'll see cortex all the way around. And then what's the third differential if you're thinking about porencephalic cyst versus...
schizencephaly, open schizencephaly.
And so what would you want to see there?
So that instead should be lined by grey matter.
What sort of grey matter? This is lined by grey matter too.
Heterotopic or abnormal appearing nodular grey matter. Yeah.
It's always polymicrogyra. And what else does it have to be if it's called schizencephaly or schizencephaly? It has to communicate with the ventricle.
Yep.
Which this one doesn't. So note here how all of these gyri, you can count these two gyri here are these two here, right? Or maybe even these two, probably these two. They're all sort of compressed. You can still see the normal anatomy that's being pushed rather than in porencephaly there's brain missing. Good. Now there's one more finding which is incidental and might not even be real. I saw that. What did you think? What do you think I thought this was before I looked at it more carefully? And
a lipoma.
What sort of lipoma?
Interhemispheric lipoma.
Yes.
But the corpus callosum looks normal.
So what type of pericallosal lipomas do you know?
There is the tubulonodular.
Which is where and what's it associated with?
Corpus callosal agenesis.
Yeah, and it's usually anterior.
Yeah.
And it's nodular. It's a lump of fat, and it's usually callosal agenesis, and it often extends into the lateral, the frontal horns of the lateral ventricle. So if we're, say, here, this is absent, the cingulate gyrus is sort of inverted, and the lipoma extends into the frontal horns. Yep. Mm-hmm. And the second sort, which would be this one, if this is fat, which I'm not sure it is.
Curvilinear.
Curvilinear, and that's the location for it, and it's usually not associated with any callosal abnormality. So if this isn't fat, what else could it be? It might just be slow flow or flow-induced signal in a vein or something on T1. Okay. I'm trying to see if there's chemical shift artifact around there to account for it, but I'm not sure. If we had a CT, we could sort it out easily, or some other, I don't know, maybe gradient might show some blooming or some fat suppression in that area. Yeah. Alrighty. Let's move on. Matchstick, over to you. Case number 2.
Great stuff.
Head trauma, motor vehicle accident, 35-year-old male. Start with the CT. Tell me what you're looking at.
Could we go to the bony reconstructions axial to begin with?
Yep.
I'm actually waiting for your... there you go. There's your screen as well. I'll get it up here too. And if we scroll to the vertex to begin with.
The other vertex. Yep, there we go.
Yeah. And then we'll come down. And
you're scrolling on your own version, right?
I am, yeah. Good. And there's some swelling over the left frontal bone with a subcutaneous hematoma. And as we track more inferiorly, there's a rim of pneumocephalus deep to the inner table of the left frontal bone. Mm-hmm. A bit further posteriorly, you can see some flecks of material with similar signal characteristics and attenuation to bone. So it could represent bony fragments or amorphous calcification in that left frontal lobe area. And then coming a bit more further inferiorly, another locule of pneumocephalus. And if we go through the orbits, there's some probably intraorbital gas, but we'll review that on coronals. There's some opacification of the, so that's looking intraorbital. There's some opacification of the anterior and posterior ethmoid sinuses and nasal bone fracture, but the bony nasal septum itself looks relatively straight.
Yep.
The pterygoid plates, they're only partially captured on this axial. They looked intact.
Okay. Let's assume the fractures are confined to the orbital roof. Well, let's not worry about anything.
And so we'll go to coronal now.
Bone again. Yep.
Bone, please. Yep. And so that confirms some of the findings. There's an orbital roof fracture on the left with pneumocephalus that is just above it, and then some intraorbital gas that looks extraconal in location. And then in the right as well, there's some, in the right orbit, there's some gas too. There are no orbital floor fractures or involvement of the infraorbital canals.
Mm-hmm.
Reviewing the lamina papyracea.
That's fine.
I'm not convinced there's anything there. So now we'll go to the soft, just the non-contrast. There's an area of low attenuation centered around those bony flakes in the left frontal lobe. There's some effacement of the sulci of the left frontal lobe in that area. Mm-hmm. I don't identify any extra axial hemorrhage, but I'd use subdural windows and perhaps thins to further interrogate that area. But it's looking more like a contusion in a coup location. Looking at the right cerebral hemisphere and posteriorly in the cerebellum, I couldn't see any contusion in a contra-coup distribution. No mass effect with the septum essentially midline and the ventricles not enlarged. The temporal horns looked of an appropriate size. I didn't find really any intraaxial hemorrhage. So the findings are in keeping with trauma associated with orbital roof fractures and a left frontal bone contusion. One thing that I'm trying to find is the bony fragments in the left frontal lobe. Has that arisen from the orbital roof, or is there another process that was at play simultaneously? But in the setting of the trauma with that contusion, I favor it to be bony fragments from the orbital roof.
And that is exactly how it was reported.
Oh, okay. But, I mean, could it be an oligodendroglioma there as well?
So what do you need to do to work this out? Because I think the temptation is certainly to assume that these are bony fragments, right? But if you look at them...
Yeah, sorry, you're lagging there a little bit.
Sorry, the temptation is certainly to attribute it all to one process, and that these would be bony fragments. The problem is they're quite big.
Yeah, they don't...
Right? So, I mean, that longer one is, I don't know, 1.5 centimeters long, and it's curved and goes over 4 or 5 slices. There should be a really big defect somewhere. You need a donor site, and we're not seeing that at all. There's a small fracture here, which is depressed into the orbit, and nothing's blown up into the frontal region. So the problem, of course, with this is that if it's just a contusion, it might only be followed up with some CT. I'm not sure if necessarily you'd have to dig those out. I think fragments of bone and depressed skull fractures increase your chance of epilepsy. But there's not much mass effect there. Given contrast, not much enhancement. I'm not sure contrast adds very much in this setting, really. So what's the real test?
MR.
Yes.
Or, I mean, if you had prior to compare to, if for some reason this young person had a prior CT brain, that'd be useful, but I doubt it. So MR.
Well, if they had a prior CT and it showed an abnormality there, it would probably mean that they already had a diagnosis. And if it was normal, unless it was very recent, it wouldn't help very much.
Yeah, because it could have grown in the interim.
Yeah. So MRI, okay. Tell me about the MR. So this is done same day after maybe.
Okay. So we'll start with axial T2 that you've got there. There's increased T2 signal in the left frontal lobe that has some septations within it and some low T2 signal foci in it as well. It is associated with local mass effects, as noted on the CT, with that effacement of the sulci overlying it. We'll now look at flare. We've got that. Within it are some areas of suppression centrally, but peripherally it's got a relatively homogeneous thick rim of increased T2 flare signal relative to both gray and white matter.
Yep.
And now we'll look at T1 quickly, and then the T1 axial relative to the post-contrast. It's essentially the T1 signal is low signal intensity, similar to CSF, and then that thick rim around it is of similar signal intensity to gray matter. And on the post-contrast axial T1, there's some dural enhancement.
Are you surprised by that? The word you're looking for is no.
No. I mean, you've got the contusion there. So, well,
there's a fracture and there's pneumocephalus, right? So if you fracture the bone, the underlying periosteum, which we covered last time with the parietal layer of the dura is periosteum. If you fracture bone, you expect the periosteum to be inflamed, right? So you're going to always have pachymeningeal or enhancement over the top of a fracture that's bad enough to have stripped some of the periosteum off the bone to introduce air between the periosteum and the bone, which is where that gas is. Yep.
And now we'll look at diffusion restriction. There are
So I'm just jumping straight to ADC.
ADC,
I don't want to be confused by DWI, right?
Yep.
I know where to look, so I just want to assess diffusion. Yep.
I don't see diffusion restriction.
Oh, what do you mean by that?
Well, I'm looking for a low ADC value.
Okay, so you don't see low ADC values.
No.
You see diffusion restriction, because if you measure this, what number would you get from the lump?
Ooh, minus like 500?
Minus 500?
Or 500?
What's normal brain? Up here in the white matter, if you measure that, what would you get?
I can't remember.
All right, we'll cover that as well. All right, so you'd get 750 in the white matter.
Okay, yep.
Times 10 to the minus 6 millimeters squared per second. That's the unit. CSF is about 3,000. And so if you're talking about no diffusion restriction, the only thing on this image that shows essentially no diffusion restriction is CSF. And even that diffusion restricts a little bit because those water molecules are bumping into each other, right? So brain diffusion restricts a lot. Normal brain is quite diffusion restricting. And this area shows facilitated diffusion compared to normal brain. So it's not normal brain, but it's not more diffusion restriction like you might see in a stroke or in, say, lymphoma or an abscess. Yeah?
Okay.
And susceptibility weighted imaging predictably shows some areas of low signal in the middle. We know that there's calcium in there. Yep.
Yep.
And cell blood
I didn't think
volume.
there was much I didn't think there was much increase in cerebral blood volume there.
No, I agree.
Yeah. Yeah.
Okay. So what do you think this is?
Look, I think you could consider an oligodendroglioma.
And that's what it is. So the key feature here is one, on CT, that they don't have a donor site for all that calcium. Two, if you had chunks of bone thrust into your brain, you're not going to be able to do that without hemorrhage. You cannot push that much bone through the frontal lobe without having a hemorrhagic contusion. Yeah? And then when you go to MR, you can see that a lot of this tissue is cortex. If you look particularly on T2, you can see whole areas of gyri that are expanded by non-enhancing tissue, which is typical of a glioma. All right, now let's talk about oligodendroglioma. So how do you make the diagnosis? When you say oligo, what does that mean?
Well, to me, it means a low-grade glioma, a grade 2 glioma. To make the diagnosis, you would need histopathology, wouldn't you?
Okay, so you get histopathology, and it comes back and it looks like an oligodendroglioma. Is that what's required these days?
I think these days you have to look at the genotype of the tumor. You have to look at the molecular genetics and the 1p19q co-deletion. Yep, and then IDH.
Yeah, so they're the two so let's review this, because in most tumors, the molecular fingerprint or makeup of tumors isn't super relevant to radiology, but in this case the whole classification system is based upon it, and you're not going to make any heads or tail of what people are talking about unless you know this. So histology, they might describe features that are those of an oligodendroglioma, but really what we're talking about is a diffuse glioma, and it might have oligo features or it might have diffuse astrocytic features, but they don't make the diagnosis these days. You need to do IDH1 testing. And how do we test that?
Well, I mean, you want to see if it's wild type or it's mutant, essentially.
Yeah, so what test do we do first? So it's IDH. And we do... Have you seen those brown stains? What are they called?
Kind of an immunohistochemistry sort of stain, or
that's right. So they're immunohistochemistry, and that's what we do. But it only tests for one mutation, which is the R132H mutation, which means the arginine at position 132 is replaced by histidine due to a single base pair change. And that is on the IDH1 gene. There are two, right? There's IDH1 and IDH2. IDH1 is cytosolic and IDH2 is mitochondrial. Same gene, does the same thing. Both found mutant in low-grade gliomas. This mutation accounts, well, IDH1 mutations account for 85, 90% of all IDH mutations. And R132H accounts for, about 80 to 85 of all IDH1 mutations. So when you do this test, if it comes back positive, in other words, mutant, then you go on and do 1p19q assessment. Okay, so this is your first test, and this is your second test. And if that comes back, so what's oligo, deleted or not deleted?
I think it's co-deletion.
Yeah, that's right. So if it's co-deleted and you've got an IDH1 mutant, then you can call it an oligo. Okay, so it's IDH, not one, just IDH mutant and 1p19q co-deleted. Okay, so that's there. If up here this is negative, what do we call it?
Would you? Would that be a higher grade diffuse glioma then? With that?
Nope.
Nope.
So what you call it is nothing. You say that the immunohistochemistry is negative, and then ideally, and we'll talk about when you don't do this. Ideally, you then do IDH sequencing to look for non-R132 IDH1 mutations and IDH2 mutations. So if the sequencing comes back as mutant, you can do 1p19q and you get down here. So the mutant here can be the common R132H mutant, or it can be any other combination of IDH mutations. If this is negative, then we have an IDH, what do we call it when it's negative?
Wild type?
Yeah, wild type. Okay, and then it can't be an oligo, so it's an astro, diffuse astro. And importantly, it'll be called a diffuse wild type astrocytoma, even if the histology is that of an oligodendroglioma. You can't be an oligodendroglioma if you don't have IDH mutation and 1pq co-deletion. There are some tumors that seem to be truly wild type that have 1p19q co-deletion, but no one knows what to call them yet. And if you're intact down here, so no co-deletion, we'll call it intact, then you have a tiny little box, because I didn't really plan this out. You have another diffuse astrocytoma, but this is IDH mutant. Okay, so they're the three diagnoses available to you. If you don't have availability of this, or if you don't do it all, then you go back to using just the histology, and you have to append the not otherwise specified, the NOS. So you can be an astrocytoma or an oligodendroglioma NOS, but that just means we don't actually know what it is. It looks like an oligo, but we don't know what it is. What's important to realize is that if you look at the histology diagnosis versus the molecular classification diagnosis, it's not perfect, the overlap. So in most cases, things that look like an oligodendroglioma will turn out to be mutant and 1p19q co-deleted, and they all make sense. But you'll get some cases where they look like oligos but don't have the molecular diagnosis, in which case you still call it an astrocytoma. Or you'll have something that looks like an astrocytoma, but it comes back 1p19q co-deleted and mutant, so you'll call it an oligodendroglioma. So this not otherwise specified, or reading old literature where they don't prove things molecularly, you're talking about a different group of tumors. You really can't extrapolate between the two. Now, just as a last thing to mention, you don't sequence everyone. And the reason for that is that the likelihood of IDH1 mutation is very age dependent. So if we look at the likelihood of having an IDH1 mutation of a low-grade tumor, okay, so at about, say, 50 years of age, and then, say, 80 years of age, until about 50, you're almost certain to have an IDH mutation. At 80, you're almost certain not to have an IDH mutation. And it's a really sharp drop-off. So depending on how much money you have to throw around and the appetite of your clinicians to deal with uncertainty, at some point between 50 and 80, you stop sequencing if you get a negative immunohistochemistry. I think the WHO says 65, maybe. But, you know, it all depends how many times you want to be wrong. Generally, if you get a negative immunohistochemistry in a young person, even though you're almost certainly going to find a mutation, you really do need to sequence, because if you don't find a mutation, if it's truly a wild-type tumor, what does that mean? What are the
treatment paradigm would be different, wouldn't it? It's going to be more aggressive.
Yeah. So treatment paradigm, but prognosis. So here it's, I think, worth. So we used to group just according to grade, right? GBM grade 4, anaplastic grade 3, and low grade grade 2. And we did that because of prognosis. And if you did a survival curve where you start off with 100% of people at diagnosis, and over time, grade 2s would do something like that, grade 3s would do something like that, and glioblastomas would do very badly, right? Pretty much universal death by a couple of years at most, usually weeks to months. But what was realized was that within this low-grade group, there were some people did really well, and some people did really badly. So there was a group that did sort of that, and there was another group that basically behaved like GBMs. They just weren't that common. And this is where IDH comes in. So this is your IDH mutant group, and this is your IDH wild type. And when you're talking about IDH wild type, the other term that's used is stealth GBM. Essentially what you've got is you've caught someone a couple of months before they would otherwise be diagnosed with a GBM. And very, very quickly, they'll develop enhancement and necrosis. So if you have a young person and it's a truly IDH wild type, you're going to really want to treat them with neoadjuvant chemo radiotherapy straight away, STUP protocol, as if they had a GBM. Whereas if they're mutant, you know it's going to have a more indolent course and you don't really want to irradiate them necessarily early on, although there's controversy as to the best management for low-grade tumours, and some people would advocate treatment early on. So you really do want to prove that it's a mutant, or more importantly, prove that it's wild type. One thing to notice is wild type means normal. So if you biopsy a normal part of the brain and do IDH testing, you'll get wild type. So you occasionally see circumstances where there's a reactive process that's not a tumour. And low-grade tumours, if they're not very cellular, can look a bit like reactive brain. And then you do IDH wild type and it comes back, IDH testing comes back wild type, and suddenly you've given the diagnosis to someone of a very aggressive tumour, whereas in fact they've just got normal brain with some other pathology. So just, wild type, just because it's what all of us have in normal brain, does not make it a good thing when it comes to a low-grade tumour. Now, this is only true for low-grade gliomas. So pilocytic astrocytomas and subependymal giant cell astrocytomas, etc., you're not expecting IDH mutation. It doesn't mean anything. You'd expect them to be wild type. Okay?
Oh.
And just to remind you before we finish, because still, despite all the years, still ADC values seem to escape you. ADC is a measurement. It's like Hounsfield unit. The numbers are in 10 to the minus 6 millimeters squared per second, or some scanners will do 10 to the minus 3. So, but that's stupid because you get silly numbers. So 10 to the minus 6, you would have normal CSF would be about 3,200, say, plus or minus a bit. Normal white matter would be about 750, plus or minus a tiny amount. Like, it's really very well conserved if it's normal. It'll go up in chronic small vessel ischemic change as there's more extracellular space for fluid to move around. Low-grade tumours, so a grade 2 astrocytoma, will be around 1,200. There's a lot of variability here. Glioblastoma will usually be back to normal white matter, and something like lymphoma will be lower than normal white matter, say 600. Stroke will be, depending on reperfusion and other factors, age, will be, you know, between 600 and 400, say. So when you say there's no abnormal diffusion restriction, I don't know what that means, because if you don't know what the thing is, it doesn't help me that you're not giving me a number. It'd be like saying there's no abnormal CT density in a lump. What you mean is, you know, give us a number or tell us what it's similar to. Anything other than what it's meant to be if it's brain is abnormal in both directions, abnormally facilitated or abnormally restricted. I'm sure we will cover ADC values again, knowing my penchant for it. Any questions about all of that?
No, it was good. Thanks, Frank.
So if you have a look, this is the... So this was an anaplastic oligo. I think it's worth mentioning that if you are an oligodendroglioma, so in this case, we've got IDH R132H positive. So if you've done it on immunohistochemistry, you can stop there. And then they did sequencing, deletion was detected, so it's an oligo. When you're an oligo molecularly, it doesn't matter how much necrosis or endovascular proliferation you have, you can never become a glioblastoma. The most you can grow up to be is an anaplastic oligo. Because even if you have all those features, your prognosis is still better. Whereas in the past, pre-2016, you could become a GBM with oligodendroglioma features, or with oligodendroglioma components, maybe that was called. Not sure. All right, case 3. Elmo, back to you. Neck pain, right hand numbness, 25-year-old male.
So cervical spine x-rays in a 25-year-old male. I'm just looking at the lateral. There is significant prevertebral soft tissue thickening and swelling. And there's also bony destruction involving the anterior vertebral body and superior end plate of C3. And 3, 4, 5, 6, 7. C7, the anterior aspect of the C7 vertebral body also appears irregular. The intervertebral disc spaces, however, are preserved, and alignment of the cervical spine is normal.
So do you notice the prevertebral soft tissue swelling? So it's really, how much are you allowed usually, do we say?
So usually like a vertebral body's width in the lower cervical spine, and then about...
So where you have your esophagus, so below cricopharyngeus, you're allowed at most one vertebral body, but usually it's less. It's usually 2/3 or so of one. And above that level?
So 2 millimeters around C2.
Yeah, so anterior to the upper, it's 2 to 3 millimeters. So do you see this curved line bulging?
Yep.
Anteriorly? I think I've seen that a number of times in cases, and it's often not noticed. Everyone notices the closer straight line, which in this case, you know, it is swollen, but it's not enormous. But that line there is another prevertebral soft tissue line that's just off midline or on one side. So it's worth keeping an eye out for that line as well. I've actually seen a case similar to this, which was reported as normal because this vertical line was, relatively close, and below here was normal, and there was this massive swelling off to the side that was not appreciated. Yep. Okay. Sorry, I interrupt. Keep going.
There's no gas locules within the prevertebral soft tissue swelling, and there's no radiopaque foreign body.
Good.
So given the bony destruction and prevertebral soft tissue swelling, the findings are suspicious for ischitis, osteomyelitis of the cervical spine with a prevertebral abscess, and I'd recommend further characterization with an MRI.
Oh, so this one maybe is the one that I'm thinking of, because this was interpreted as normal. The MR is a month later.
Okay. So I'm just looking at the post-contrast axials.
Axials, yep.
So there are multiple peripherally enhancing prevertebral soft tissue lesions with central non-enhancement. Just on the T2 axials, these central non-enhancing components are bright on T2, similar density to CSF. So these would be in keeping with abscesses or prevertebral abscesses. I'm just looking at the bones now. So on T1, there's significant bony destruction, particularly involving C3, 4, 5, 6, 7. The vertebral body is deformed with anterior wedging, and there's kyphotic deformity at this level at C6, C7. Similar changes are also seen at C3.
Yep.
On the post-contrast T1 sagittal images, there's extensive enhancement of the vertebral bodies involving multiple vertebral bodies, but the disc spaces are relatively preserved. And there's also, I guess, relative sparing of the C4 and C5 vertebral bodies. So there's significant destruction at C6 and C7, as well as C3 with relative sparing in between at these levels.
Yep.
And there is some mass effect on the cord, given the kyphotic deformity, with some canal narrowing and compression of the cord, but the cord signal is... there is actually some abnormal cord signal at the level of C6 and C7.
Maybe.
Okay, maybe not a lot.
I don't know. Which projection do you like to look at for cord signal?
Well, I start off by sort of looking first at the sagittals, but then I try and confirm it on the axials to see if it's real.
Right, so the correct answer is both. Yeah.
Yep.
And it, I think cord signal, people always talk about it as if it's really obvious and easy, but it's really obvious and easy when it's obvious and easy. But in something like this, you wonder, there's some anterior linear sort of subpial high signal, which you are tempted to call, but then when you look in the upper thoracic spine, you get areas of anterior subpial high signal as well. Remember, there's in the cord, there's an interhemispheric, well, there's a left to right division, and anteriorly it's quite deep. So you can have a little bit of a sulcus going down anteriorly. And so if you happen to have relatively thin slices on sagittal, and one of them lands perfectly in that midline sulcus, anterior spinal, I don't know what it's called, then you might get that anterior signal, which is anterior to the central canal of the cord.
Yeah.
And then when you go to axial, you can see that there's a central canal and there's a little sulcus in front of it, but there's not much additional signal. The problem with axials is that you can't compare the cord at the level that you're worried about to the cord above without scrolling, which is the big advantage of sagittal. You can see the whole cord in one line. Something that's sometimes helpful is tiling the stack on your PACS workstation. So bringing up 16 slices and zooming up on the cord so that you can see them all at the same time and see if it's brighter on axial. I'm not sure. There might be a little bit of high signal, but it's not dramatic. Yeah. Okay, so what do you think this is?
Tuberculous spondylodiscitis.
Yeah, so you mentioned some of the features that are classic for that, and that is a bacterial discitis. Where does it start?
At the end plates?
Yeah, that's right. So it starts just at the end plate. So we'll draw two. I'm just enjoying myself doodling. So if we've got some vertebra here, and we'll do some TB vertebra over here. Here you go. So I got this amazing spine. You can get I'm getting bored on the right. It's getting all messy. So a bacterial infection will start in the end plate because it's sort of end arteries. The arteries come in and sort of supply, and it's relatively poorly supplied like that. And so infection will start here and immediately pretty much go into the disc. And so before it's gone up into the rest of the vertebral body, with this really being well supplied by blood, therefore well supplied by blood cells, red white cells, it'll set up infection in the disc and will destroy the adjacent end plate before it does any real damage to the other vertebrae. And you'll get, coming out, and then it'll go into the prevertebral soft tissues, and you'll get a phlegmon initially contained by the posterior longitudinal ligament, but eventually into the epidural space, etc. In TB, I don't know where the infection starts, but it doesn't spread into the disc. In fact, it spares it. It tends to come out anteriorly, and you get subligamentous spread. So the infection comes up deep to the anterior longitudinal ligament and deep to the prevertebral musculature, and then goes into bone. And so you get this involvement of, really prominent involvement of bone, sparing the discs that are left behind. And they can become massive collections because, remember, TB is not as pyrexial as bacterial. So people don't feel as well. That's why they're called cold abscesses. And if you look here and look at the size of these abscesses, it's massive. This person's been wandering around well enough to not get an MR after the cervical spine for a month. So they're not that sick. If this was Staph aureus, you'd be in ICU and, grossly septic. And look how beautifully these discs are preserved. You can even see this disc almost floating with no vertebral body. So there's really no differential when you see this size, especially in a patient that's not terribly unwell and TB. I think there's a couple of other atypical agents that can have very similar findings, but they're rare. So brucellosis, I think, can look very similar to TB from memory. Don't quote me. Good. TB. Who was Pot?
A surgeon.
Probably. That's not what he's best known for.
Pot was the founder. He was the founder of occupational medicine, Frank.
There you go. Yes, indeed. Why?
Well, he picked up scrotal tumours in chimney sweeps.
It's amazing that you know that, isn't it? You must have some amazing teachers. That's right. Chimney sweeps, scrotal cancer, and instituted showers or washing for chimney sweeps and eradicated the disease. Lucky chimney sweeps. Case 4. Back to you, Matchstick. We'll call this the last one, okay?
Okay. Could we please start with, axial T2 fat stat demonstrates an abnormality localized principally to the right petrous apex. There's posterior bowing of the dura that extends posteriorly to the pons. The lesion itself is characterized by what look like little locules of T2 hyperintense signal on the T2 fat sat, similar intensity to CSF. The right petrous ICA is displaced anteriorly. The signal characteristics of the cochlea and semicircular canals appear similar to the left, so they appear to be spared. Tracking inferiorly, difficult to see if it extends into the clivus, but I think it might. I'll look at the T1 signal characteristics. Now, it looks like an expansile lesion. On T1, it's similar signal intensity to the gray matter. And we'll look at, do we have a post-contrast? Let's look at a post-contrast T1 fat sat. There is irregular heterogeneous enhancement throughout the lesion. Looks solitary. Favor it to be centered, as I've already said, in the bone. Coronal T2 to see if there are any flow voids in it.
What are you thinking?
I was thinking a paraganglioma with flow voids.
Good.
And with the fat sat, I don't think, because we had a T2 and a T2 fat sat, it doesn't look like the little locules are saturating out. So I don't think it's really got little locules of fat in there.
What were you thinking there?
I was thinking, what was I thinking? I was thinking let's see, a cholesterol granuloma doesn't fat sat. So not a cholesterol granuloma. And looking at diffusion restriction, thinking cholesteatoma, which would demonstrate diffusion restriction. This doesn't.
So what would a cholesteatoma look like on diffusion?
So a cholesteatoma, I think of essentially, this would be a congenital probably, I think of as an epidermoid cyst. Yep. Essentially kind of a similar sort of process. So I'd expect diffusion restriction.
But what do you mean by that? What would it look like? On DWI, what signal would it be?
It would be, well, low on ADC.
See, I knew you'd say that.
You're leading me to it.
The
error of my ways.
I'm so not. I'm so trying to save you. So it's going to be really bright on DWI, right?
Yeah.
So that's fine. But that's DWI, only one component of it is true diffusion. The other component is T2 signal. When you go to ADC, if you're expecting an epidermoid or a cholesteatoma to be low on ADC like a stroke, then you will not call it because they never are that low. In fact, epidermoid cysts diffusion restrict as much as normal brain.
Right.
So they'll be mid-grey around 700, say. But they're super bright on T2. They have a very high T2 signal component to their diffusion-weighted imaging, so that on DWI it's very bright. Now, some people call that T2 shine-through. Personally, I have a real issue with that term. I think it's stupid. Because all the signal that you're seeing on DWI is residual T2 signal that hasn't been removed by diffusion effects. So the reason you can see normal brain is T2 shine through. I think when people say T2 shine through, they mean this thing that's really bright that I initially thought was going to be a stroke turns out not to be a stroke, because whatever, it's stupid, don't use it. Just use diffusion characteristics. So this is not probably an epidermoid cyst or a cholesteatoma because its diffusion values are too facilitated, too high for it. They're clearly much brighter than normal brain. So if you had to guess, it's probably 1600, say. And you can put a ROI on it and measure it. And have a look at the next 10 epidermoid cysts on ADC and measure it. The solid components of them are always very close to brain. So if anything, the diffusion here is too facilitated for it to be an epidermoid. And yes, it's also not bright enough on DWI. Anyway, sorry. You know I've got a thing about that.
Yeah,
So,
no, and I'll develop
and
the thing
therefore
eventually.
You should just learn it
Yeah,
and stop me
yeah.
getting annoyed at you.
Yep.
All right, good. So what do you think?
Well, so I was starting to think a chondrosarcoma.
Okay, so what's your differential first?
So my just morphologically in petrous apex lesions, I was thinking a cholesterol granuloma, a paraganglioma, a cholesteatoma,
Yep. So
maybe a meningioma.
Cholesteatoma. What else did you say? Meningioma? Yeah, all right. Maybe.
Yep.
Maybe
But like I
Yep.
don't really like that for this.
What else did you want?
Paraganglioma.
Paraganglioma. What else?
And then I was going a chondrosarcoma.
Chondrosarc, yep. So that's nice because it's high on T2, huh? So of the features of this lesion, the thing that's really striking is how bright it is on T2. So if we think about these meningioma, some of them can be bright on T2, but it's generally not that common. Cholesteatomas, sure, but they're usually super bright on T1. Cholesterol granulomas are usually super bright on T1, and this one isn't. Yep. So I think we can kind of cross that off. Cholesteatoma, we've talked about. The diffusion's all wrong for it. Plus, this thing enhances, and cholesteatomas don't. What else? If you're talking about really bright T2 things in the base of skull,
one really more. Bright. A chordoma.
Chordoma, yes.
Well, is that more midline though, or could it be kind of midline and it's kind of gone off to the side or something?
So you do get chordomas that are off to the side. But this one is very off to the side. Okay, but it gets to the midline, and usually they grow posteriorly backwards and push into the pons. But I think when you see such a bright lesion, you really can't not put in chondroid lesions or chordoid lesions. And note that when I say chondroid lesions and chordoid lesions, that includes rare chondroid and chordoid metaplastic meningiomas, but they're rare, and you'll get it wrong. You'll basically never just say, hey, that's what it's going to be. Or if you ever do say that, it means you're getting it wrong most of the time. Okay, so there's one more lesion. So what would you, if you were reporting this, what would you be wanting to look at or suggesting that should be obtained?
I just like looking at non-contrast CT brains to look at the bony involvement.
Okay, and how would that be helpful with this list? What would chondrosarc show you on CT?
Rings and arcs.
Yep, so you get chondroid calcification, right? Popcorn-like, yep. What about chordoma?
Ooh.
Does it ossify or calcify?
Can't recall precisely. I don't think so.
No, it doesn't. But it destroys bone.
Yeah,
and
aggressive.
Can leave behind little spicules of native bone that it hasn't destroyed. So you might see little flecks of bone in it, but the bone's destroyed. Okay, paraganglioma.
Well, they can look very aggressive, and they can really chew through the bone.
Yep, they chew into bone rather than chordomas that come out of bone, right? So they're usually irregular margins of all the bone that they touch as they grow into it, and it's irregular and ugly. And why is that a useful sign to compare to what other lesion that we usually think of when we're trying to when we're thinking about paragangliomas? What's the main differential that we're trying to...
A schwannoma.
Yeah, and how do they...
And, well, that would be smooth remodeling and, not looking nearly as aggressive or erosive.
Yep. Nicely smooth, scalloped margins. Okay, so if we have a look here, MR's hard, right? But where we see it, if you look at the midline of the clivus, it looks pretty well defined. It's not too horribly aggressive. There's one more clue. I'll show you the coronal T1 maybe. Scroll anteriorly where you can see the tongue. What do you see with the tongue?
Oh, in terms of the atrophy.
So there's fatty atrophy, right?
And so the hypoglossal nerve is involved, so kind of a cystic schwannoma.
That's what this is.
Ah, cool.
Now, there's finding the hypoglossal nerve canal on MR it should be easy, but...
Sorry, you're getting a little bit laggy there.
Sorry, finding the hypoglossal canal on MR or CT should be easy. But because there are venous emissaries through the base of skull, and there's the pars nervosa of the jugular with the inferior petrosal sinus going into it, sometimes you can get caught out. And there's one landmark that's very, very useful on coronal, and it's this this appearance, the eagle sign. I hate signs. Well, I don't hate them, but this is the eagle sign. And because I'm finding a new love of drawing, it is, you have a sort of bald eagle looking thing with a beak. The hypoglossal is under its beak. That is a very easy to identify landmark. So there it is. That's the hypoglossal nerve tucked in under the beak. And when you look at the other side, that's pretty much the epicenter of this mass. So it's not really petrous apex, the epicenter, which is up here. Doesn't mean this couldn't be a petrous apex mass. This just happens to have grown mostly inferiorly. But if you're going to go using the epicenter kind of idea, then this fits well with the hypoglossal, which also fits well with the fatty atrophy of the tongue. So schwannoma of the hypoglossal canal, of hypoglossal nerve. Any questions about all of that, folks? Before we
that was great, Frank.
Cool. Have a lovely day. I'm going to go play Paint War Warhammer figurines with the boys.
Okay, good stuff. Thanks, Frank.
Thank you. See you guys. Bye-bye.
Yeah.
Bye.